So, good evening, viewers. A long time we are again meeting for Neuro Pathshala lectures. This time we'll be talking on or discussing learning on synucleinopathies and multiple system atrophy. Very interesting topics. Let's hope that we can get some more audience before we go. We'll get into this. So we'll first briefly discuss about alpha synucleinopathies. Though the talk will be mostly on MSA phenotypes, when to suspect MSA. Before we reach MSA, we read and learn a lot about autonomic nervous system evaluation bedside. Now we'll discuss the new MSA diagnostic criteria of 2022, which appeared in April Movement Disorders Journal, and we compare them with 2008 consensus criteria. Also, supportive motor features and non-motor features will be discussed in detail. We also have a look in the MRI in MSA, what are the exclusion criteria, and what will be the research criteria for possible prodromal MSA. We'll have a case discussion type, and then we'll wind up. So there are 5 clinical phenotypes caused by alpha synuclein neuropathology. The clinical features usually they depend on the anatomical location of alpha synuclein driven cell death, whether the alpha synuclein is in neurons or it's in oligodendroglia. That depends. Why the synuclein precipitates in these various different parts is unknown. But autonomic failure occurs in all phenotypes and has 2 distinct patterns, the central and peripheral. And like MSA has only peripheral autonomic nervous system disturbance. The phenotypes are distinct but overlapping and evolve over time. So what are synucleins? Synucleins are small proteins. They are found in a synaptic terminal. They are present in nuclei of neurons in a synapse. Their exact function role is not known. A clinical phenotype and survival depends on the cell type, as I said earlier, where this alpha synuclein aggregates. And if it is in primary neurons, Lewy bodies are formed, or Lewy neurites, and the diseases that are associated with Lewy bodies, the Lewy body associated disorders, Parkinson's disease, dementia with Lewy body disease, and pure autonomic failure. All these have a characteristic, they have a slow progression when compared to MSA, which has got rapid progression, because here the inclusion bodies are in oligodendroglia primarily, and they are called glial cytoplasmic inclusions. That is a characteristic pathophysiology of multisystem atrophy. So in humans, it is not known what determines whether alpha synuclein precipitates in neurons, like it's in Parkinson's disease and primary autonomic failure, why it is in glial cells in MSA, why only in PAF in autonomic neurons in primary autonomic failure, why it is in striatonigral neurons as seen in PD and MSA. We are not very sure about this, why, but it happens. So this we have already seen. Now you see the misfolding of the clumps of alpha synuclein, and the clumps together forming Lewy bodies are glial cytoplasmic inclusions, and they injure the cells. You see alpha synuclein, which is unfolded here. It becomes normal folding, folds into a final shape with a biological function, which probably helps in synaptic transmission. This can get unfolded or misfolded, morphs into toxic species prion. This misfolding, they clump together, forming Lewy bodies or glial cytoplasmic inclusions and the injured cell. And these things, they can spread to other cells. Also type of prion disorders and alpha synucleinopathies. So Lewy body syndromes are characterized by cytoplasmic or eosinophilic neuronal inclusions in brain and peripheral autonomic nervous system. But in MSA, it is main topic of ours today is only brain, basal ganglia, cortex, spinal cord has cytoplasmic inclusions. So you can see the distribution of alpha synuclein In Parkinson's disease, you can see it is present in the peripheral autonomic nervous system as well as in the brain. And how is it different from Lewy body disease? Lewy body disease is also in cortex. You can see that in the cortex. And how it is in multiple system atrophy, peripheral things are not involved. So MIBG scan is normal. It is only in the spinal cord and the brain. The alpha synuclein precipitation in glial cytoplasmic inclusions seen only in these areas. The one was a pure autonomic failure where it's present only in the peripheral nervous system. And the REM sleep behavioral disorder also comes under this category, and you can see the brainstem involvement in this. So this is a major differentiation of all the things. But one thing one should realize is that autonomic nervous system dysfunction is a characteristic feature. As I said, the clinical features re-emphasize depend on the anatomical location of alpha synuclein driven cell death. Autonomic failure occurs in all phenotypes and has two distinct patterns, central and peripheral. The phenotypes are distinct but overlapping and evolve over time. It's very difficult to diagnose when a patient comes only with postural giddiness. Some people come saying that I have giddiness when I climb stairs. When I walk for long distance, I feel giddy. When postprandially, I feel a bit giddy. So these things suggest to us there is an orthostatic hypotension, and how to measure that is also another interesting aspect which has changed of late. So these are the alpha overlapping features of alpha synucleinopathies. This is MSA, prototype Parkinson's disease, diffuse Lewy body disease, autonomic failure, and REM sleep behavioral disorder. So the Parkinsonism, cerebral ataxia, cognitive impairment mild, which is more in DLB. Autonomic dysfunction is MSA, DLB, and autonomic failure. But in PD, it is late to occur. Similarly, if you look at hyposmia, hyposmia is not seen in MSA, but it's present in PD, DLB, and REM sleep behavioral disorder is seen in all. To some extent, it's present. So the important thing is now, as we see in Parkinson's disease, there are prodromal features that can manifest in any individual who may later develop MSA. So most of these are called prodromal features, which will come to in subsequent slides. So multiple system atrophy, as I said, in contrast to Parkinson's disease and DLB and autonomic failure, post-ganglionic sympathetic neurons are typically preserved in MSA. You can see they're all intact in MSA, and the heart things are also intact. So MIBG scan is normal in this. So the cardiovascular dysfunction, gastrointestinal dysfunction, genitourinary dysfunction, pseudomotor dysfunction, these are the autonomic deficits that are encountered in synucleinopathies. So we have to have a good knowledge how to test them bedside. That's going to be a very important aspect of this talk. As I said, in PD, DLB, and PF, post-ganglionic degeneration occurs. Cardiovascular sympathetic dysfunction is seen. The cardiac MIG uptake is almost always reduced in these conditions, even in the early stages. The MIG scan is a very important aspect. In multiple system atrophy, the cardiovascular sympathetic function is not affected. It may be either normal MIBG scan or slightly reduced in MIBG. So that's a major difference. So you can see intact cardiac innervation excludes PD, but it can be reduced, does not exclude MSA. So this is a control where you can see the scan which is showing, and MSA, there is no denervation. But mild denervation may be seen in some cases. Some cases may severe denervation, but those are rare. So 30% patients with MSA do have cardiac sympathetic denervation. But one thing is sure, it is intact cardiac innervation is excludes the Parkinson's disease. That's important aspect. So you can see there are studies where these odds ratios have been calculated. The important point in this slide, olfaction. The olfaction, if you look at this, it is normal. It is preserved in MSA. Olfaction is preserved. It's lost in PD and DLB, and Primary autonomic failure also has got the REM sleep behavioral disorders, and they are commonly seen in all these phenotypes. So maybe we'll touch on multiple system atrophy, but in between we'll go in depth into autonomic nervous system assessment and bedside. So as you all know, MSA is a rapidly progressive sporadic neurodegenerative condition. It is not hereditary, mind you, it is a sporadic condition. It's commonly seen in men in fifth to sixth decade with a prevalence of 4 to 6 cases per 1 lakh. And the core clinical features are dysautonomic features, that is orthostatic hypotension with any other autonomic dysfunction features, bladder and bowel dysfunction, temperature regulation, etc. And in association with this autonomic dysfunction, there will be the Parkinsonism, cerebellar ataxia, or both in different combinations, and also there may be upgoing plantar. The pathology, as I said, is in MSA, glial cytoplasmic inclusions, which are precipitated alpha-synucleins, and the neuronal loss is because of their toxic effect on the cell metabolism. They're also seen in striatonigral and olivopontocerebellar systems. See, when MSA came into vogue, we used to read it as striatonigral degeneration, Scheid-Drager syndrome, olivopontocerebellar atrophy. All of these three things used to be combinedly called as MSA. So this Graham and Oppenheimer, they named MSA when the features suggest of what all the three I said, SND, OPC, and SDS, Scheid-Drager syndrome. Probable MSA, presence of orthostatic or any other dysautonomic marker in association with Parkinsonism or cerebellar signs. So examination of cerebellar signs is very important in Parkinson's disease. Also, the blood pressure measurement in lying and supine. So if you look at the motor features are more common between MSA and PD. That's why there is a lot of confusion. More than 40% of PD patients develop ANS features, but cardiac dysautonomia in PD is due to a loss of catecholaminergic neurons outside the brain. But in MSA, the cardiac autonomic nervous system is well preserved. So the phenotypes, we can say that depending on the predominant motor symptoms at onset, Parkinsonism, MSA-P, that is, then the other one is MSA-C, where cerebellar syndrome is predominant. So when it is MSA-P, we have to differentiate it from Parkinson's disease as well as DLB and progressive supranuclear palsy, which is a tauopathy. The cerebellar syndrome is the idiopathic late onset cerebellar ataxias and spinocerebellar ataxias. So these are the it's idiopathic and cerebellar ataxias. All these things, these are late onset cerebellar ataxias are very common, very commonly confused with this. So whenever a person has cerebellar syndrome and autonomic features, you try and look for Parkinsonian feature also, and then we can come to a conclusion and diagnosis. So what I was telling is the progression of MSA. Earlier I mentioned that prodromal features or onset of premotor symptoms has also now been recorded in MSA. This we saw only in Parkinson's disease, but in this neurodegenerative condition, when the neurodegeneration starts, there is a preclinical phase, premotor phase characterized by neurogenic orthostatic hypotension, the REM sleep behavioral disorder, erectile dysfunction, neurogenic bladder, and stridor. These are the important features. So with the onset of motor symptoms, you'll have other features like gait disorders, bradykinesia, ataxia. So these will our motor symptoms will so that's when we diagnose this condition clinically. So but something is happening always before where we can think if there are new therapies available to prevent further progression, that will help us. The second consensus statement on the diagnosis of multiple system atrophy was published in 2008 in Neurology, but the diagnostic criteria given in that are useful. They are not perfect. The patients are identified once the disease is clearly established. Now we should be able to clinically establish the diagnosis with certainty, not after death by neuropathology. They do not provide any tools to identify MSA patients in the earlier stage of the disease. Now, when we discuss the new diagnostic criteria, there we can have a clear, no, definite confidence in diagnosing it. So previous criteria, there is a definitive MSA neuropathology after death. Here neuropathology is there, there is not, but the probable MSA has been replaced by two entities, what is called the clinically established MSA, clinically probable MSA. These are the two. So now we can, with confidence, if we learn how to examine the patient correctly, we'll be able to diagnose MSA clearly. And a possible MSA, possible prodromal MSA is the recent thing, that is when the research criteria will come. So you have neuropathologically established MSA, clinically established MSA, clinically probable MSA, and the prodromal phase, which is the research arena, possible prodromal MSA, where a lot of research can be done, is the second. So these are the new diagnostic criteria, which we'll see in detail and learn a few things about the examination part. So neuropathologically established MSA, there is no change from previous criteria. They are widespread and abundant glial cytoplasmic inclusions. They are positive for alpha synuclein. And these changes are seen in striatonigral and olivopontous cerebellar structures. If you look at the control smear as a brain parenchyma, and you can see the lower bodies or the alpha synuclein precipitates here. So this is the neuropathology of MSA. Right, very nice. And so next, what we are going to do is we'll see what is this clinically established and clinically probable. Most important thing. So one of the essential features you should realize is it's a sporadic, progressive, adult onset disease more than 30 years. It's never seen below 30 years. The core clinical features re-emphasize autonomic dysfunction. That's why this lecture we have started with so many autonomic nervous system slides. Neurological and or neurological orthostatic hypotension, Parkinsonism, bradykinesia, tremor and or rigidity, cerebellar syndromes, gait ataxia, limb ataxia, dysarthria, oculomotor dysfunction. These are the core clinical features. There are some motor and non-motor features which we see in the due course of the lecture, and there are important MRA markers which can be added to the diagnostic criteria, and there are some exclusion criteria which we'll mention. So the most important thing, what I said is, must have autonomic dysfunction and poorly levodopa responsive Parkinsonism and or cerebellar symptoms. At least cerebellar syndrome means 2 signs should be present. So these plus supportive criteria, at least 2 should be present, which we'll discuss, and at least 1 MRA criteria present. So if all these are, and exclusion of the exclusion criteria, we'll be able to with certainty diagnose MSA pre-mortem, not ante-mortem. The probable ones, at least autonomic dysfunction with Parkinsonism or cerebellar syndrome, 1 sign. So at least 2 of them should be present. Here, these 3 should be present: poorly levodopa responsive, Parkinsonism, cerebellar syndrome, and ANS dysfunction, plus 2 features of motor, which supportive clinical features, and 1 MRA marker. Here, MRA marker is not required, and only 1 feature is required, and at least 2 present. This is clinically probable. So the core features must have autonomic dysfunction, poorly levodopa responsive Parkinsonism, and cerebellar syndrome, at least 2 signs. Supportive features, which I'm going to mention, that we'll see in the next slides. The other, what are the autonomic dysfunction features? And there is a definition here. One is urinary urge incontinence. And when you do ultrasound and voiding difficulties, the post-void residue should be more than 100 ml for diagnosis. And a neurogenic orthostatic hypotension should be more than 20 by 10 diastolic blood pressure fall within 3 minutes on active standing or the HUT, head up tilt test. So this is the new thing that has come. Earlier we used to think it is 30 by 15 for 3 minutes. Now the criteria has changed the definition of orthostatic hypotension. The supportive criteria, as we have already mentioned, but the difference here is urinary urge incontinence is present, Voiding difficulties are present, but the PVR will be less than 100 ml. And here, the orthostatic hypotension is defined by a fall of 20/10 within 10 minutes on active standing or tilt test. That means you have to cater that much time for measuring the orthostatic hypotension, which usually we don't do. So this is a new thing that has come in the probable MSA. So neurogenic orthostatic hypotension is a failure in blood pressure compensating reflex, the autonomic nervous system defect. It is due to lack of vasoconstriction. The fall in blood pressure is suggestive of sympathetic dysfunction. So here you can remember two things. If it is a heart rate variability, it is a vagal dysfunction. For a blood pressure problem, it is a sympathetic. But there are other causes which also has the non-neurogenic orthostatic hypotension with intact reflexes, but they exceed reaction capacity like dehydration, anemia, medications, heat exposure. One has to be very careful to exclude these. So that's why this thing has come up. The heart rate raise divided by fall in systolic blood pressure. If it is less than 0.5, this index is very sensitive and specific for neurogenic orthostatic hypotension. So non-neurogenic is this, control is this, and peripheral. You see the specificity of this. The HR by BP. It raise, what is the raise in heart rate? What is the fall in systolic blood pressure? We divide them, then you'll show you next slide. We have one more slide subsequently where you can see if the value is less than 0.5, it becomes very significant. So aim of autonomic testing, as I said, in alpha synucleinopathies is to detect the presence of autonomic failure, to quantify severity of deficits, to determine the distribution of autonomic failure, to detect the site of autonomic lesions. So a battery of tests are designed for standardized evaluation of pseudomotor function, cardiovagal function, cardiovascular adrenergic function. Some of these tests will deal in detail, and there is autonomic reflex screen, ARS, and that screen, if you're asked an exam, you have to write these two: quantitative pseudomotor axon reflex test, QSAT, is that test the postganglionic sympathetic pseudomotor function, heart rate response to deep breathing, which is a bedside cardiovagal function test, blood pressure and heart rate response to Valsalva maneuver, which we have been reading since our college days of an MBBS, cardiovagal and cardiovascular adrenergic function. It tests head up tilt test, which blood pressure and heart rate response. It's also cardiovascular adrenergic function test. So this will touch the multi-compartmental, the sweat capsule. Acetylcholine solution is filled into compartment C, and ionophores with 2 mA for 5 minutes. Sweat response recorded from the compartment A, indirect axon reflex response. So this is a QSAT test, which we don't have to do this. We have other methods are doing, but for learning sake, you can do this. So vagus nerve is the longest of the cranial nerves. It is susceptible to injury and pathology. It contains abundant parasympathetic fibers. Cardiovagal function easily assessed using maneuvers that result in heart rate response. As I said, it is derived from a 3-lead ECG you can attach. Cardiovagal impairment is seen early in many autonomic neuropathies, like diabetic autonomic neuropathy and amyloid neuropathy. That means heart rate variability is very, very important. So the autonomic reflex screening consists of the cardiovagal function assessment. The heart rate response is measured to deep breathing, Valsalva maneuver, standing up, coughing, single breath, the spontaneous heart rate variation, which is a time domain measure of heart rate variation. That means 24 hours Holter or 5 minutes or 10 minutes. Frequency domain measure is very short. The auto it's wavelet transformation of 5 minutes. You can see that. So what I'm showing you here is a cardiovagal heart rate test. And you remember all the 3 tests: 6 breath, deep breath test, standing test, and Valsalva, which we'll discuss, and which I'll show you again. And the other blood pressure test, a hand grip test, cold immersion test, and again Valsalva test. The Valsalva test is very, very important. There is an Ewing's protocol how to do these tests. Heart rate variability analysis. Heart rate responses to the Valsalva, deep breathing, and standing up are the indices of parasympathetic activity. So one of the examples is, if you want to do this test, patient should have a light breakfast. After 30 minutes of rest between 9 to 11 a.m., under ECG monitoring, heart rate responds to deep breathing while lying posture. 6 breaths per minute. They are deep breaths for 5 minutes. That's how the response. Heart rate response to Valsalva, it's again a step pressure of 40 millimeters of mercury for 10 seconds. Heart rate response to standing is done under all ECG monitoring also. It is expressed by 30:15 ratio. The ratio of longest RR interval around 30th beat after standing up to the shortest RR interval around the 15th beat. So these three responses are, we are going to discuss again, are the for Ewing's protocol, which has to be done, and diastolic blood pressure response to sustained hand grip at 30% of its maximal strength for 5 minutes. At 30% of its maximal strength for 5 minutes. That then what is the diastolic blood pressure response? Systolic blood pressure response immediately after standing up. For with a 12 lead ECG, every 30 seconds for 2 minutes you do and calculate what I said. So each test has a normal response, a borderline response, then abnormal score. So normal pattern score has 0 to 1, borderline abnormality 2 to 4, and abnormal are more than 4. That's how all these Ewing's protocol tests are graded. So now we have already done this, then Parkinsonism, and the less than 30% improvement in MDS UPDRS 3. That means when in your Parkinsonism features are there, you started giving levodopa, and you are given up 1000 milligrams, and then there is no response. That is poorly responsive to levodopa. That is a characteristic feature. Now 1000 milligrams you have to reach. Okay. So what is, now we'll see the supportive clinical motor features which we are thinking 2 should be present for clinically established and 1 at least should be present for the probable. So these are the rapidly progressive Parkinsonism, orofacial dystonias, unexplained Babinski sign, polymini-myoclonus postural deformities. All these things are very important to understand. What is a rapidly progressive Parkinsonism? That is within 3 years of motor onset, their progression should be very rapid, leading to an assistance for activities of daily living. The individual may have severe dysarthria, may have severe dysphagia. This is the definition of rapidly progressive Parkinsonism. And the other important issue is orofacial dystonias that are exacerbated by levodopa. So levodopa induces dyskinesias in limbs. That's okay. But if it is characteristically causing orofacial dystonias or orofacial dystonic movements of the face, and if they can be induced or exacerbated by levodopa with no limb dyskinesia, then it is a feature that can make you suspect that there is underlying MSA. And when you rule out causes like stroke and cervical myelopathy, an individual has unexplained Babinski sign, that's also a supportive motor feature. And another important thing is a jerky, irregular myoclonic tremor. This is polymini-myoclonus. It can be spontaneous or posture or action related, or it also can be induced by putting a small pin over the thinner eminence. There will be mild, irregular myoclonic tremor. Normal tremor is rhythmic. Here, this is arrhythmic. And characteristically, some postural deformities are seen in MSA. That's very interesting. And if you individual has got these deformities early in their course, then it is suggestive of MSA. What are these? Enterocolis. Enterocolis, you can see here. Spine, camptocormia, Pisa syndrome, as you can see here. Head and feet. The contractures and deformities can be there in the both the legs and feet, hands and feet. And you see there was stridor I'll show you some videos of stridor, inspiratory size, cold, discolored extremities. You can see them. Pathological laughter or crying, and erectile dysfunction in men younger than 60 years. So these are the supportive clinical non-motor features. And you have seen the motor features, you have seen the non-motor features. Let's see the stridor and the sleep associated problems in this. Let's see how it goes. Let's see. So that's the stridor type. Next. This type of sleep stridor sounds. Inspiratory size you can see now while talking. Very nice. So these are the important things which I wanted to show of the sleep. That you see that sound of that's the sound which is characteristic. Okay. Now let's look at the MRI in MSA. And putamen cerebellum, middle cerebellar peduncle pons are characteristically observed, and there are some named signs, and the differences can be seen. MSA, you have more involvement of putamen on pons. You can see what are the hyper intense halo. You can see the hyper intense halo in the putamen. This is called putaminal atrophy, and it is indicated by the putaminal rim sign or putaminal slit sign. So this is a characteristic feature, but this thing can be seen in 3 Tesla MRIs also. To establish that it is abnormal, we have to look at the iron susceptibility weighted images, that is the gradient echo images, where the halo should be seen like this. So the putamen rim sign is to be accompanied by gradient echo image of hypointensity in putamen. So there is a hypointensity in the putamen. And you can see the atrophy of the brainstem, the cerebellum atrophy, brainstem atrophy, and you can see the cerebellar folia are very, very characteristically the seen. This is the control, and this is the atrophy down. And you can see the hot cross burn sign, which is said characteristic of MSA, but can be seen in other disorders. You can see the interfolia accumulation of CSF and suggestive of a lot of atrophy. And you can see the cisterns which are wide, where compared to normal cisterns here, you can see the cisterns are very wide. And this is a normal cerebellum and the cerebellum in atrophied cerebellum. And there is no hot cross bond sign here. There is a hot cross bond sign here. This is a plus-like thing which you are seeing. So exclusion criteria: hyposmia or anosmia on olfactory testing, abnormal cardiac sympathetic imaging MIBG scan, substantial and persistent response to levodopa, cognition fluctuating attention and alertness, recurrent visual hallucinations, dementia. There will be no dementia in MSA. That's must. So if there is a doubt of dementia, then rule out. Oculomotor abnormalities suggesting PSP, supranuclear gaze palsy and slowing of vertical saccades. Brain MRI features, they are suggestive of other diagnoses like PSP, MS, and vascular disease. So all these should be present for the definite diagnosis of MSA. So as per the new diagnostic criteria, this is a must. So there are some MSA look-alikes also, that is spinocerebellar ataxia, Parkinson plus syndromes with autonomic failure. So if a positive family history is there, then it's not MSA. If motor onset is less than 50, spasticity, peripheral neuropathy, seizures, element signs, all these exclude mostly. Alternative diagnoses are suggested by hummingbird sign in PSP, as you can see here. Hummingbird sign. Poor levodopa responsive Parkinsonism with urgent incontinence. There will be early falls, foot dystonia, no anosmia, reduced vertical gaze, abolished vertical optocognitive nystagmus. These are ocular signs. So they are the other features. There are some research criteria for possible prodromal MSA. And what are these? So first you have to suspect that the disease is there. Then only you can put these individuals under your care, under observation, and they can possibly enter any research protocols. So the early entry criteria is clinical non-motor features. What are these? Non-motor RBD confirmed by polysomnography. Neurogenic orthostatic hypotension, the drop in blood pressure 20 by 10 mmHg within 10 minutes of active standing or tilt test. Urogenital failure, urinary urge incontinence, and erectile dysfunction less than 60 years, unexplained voiding difficulties with a residue of more than 100 ml, subtle Parkinsonian signs, subtle cerebellar signs, and absence of exclusion criteria, what we have discussed. All these are research criteria for possible prodromal MSA. So let's look at the case. 63-year-old woman presented with lightheadedness and recurrent syncope on standing. She became symptomatic when she was about 58-year-old with a history of blurry vision upon standing and after climbing stairs, the history of talking and moving while sleeping, history of increased urinary frequency, incomplete bladder emptying, need to press on her abdomen to be able to fully void. All these features are present. And the case was investigated. I was telling you that the tilt table and the blood pressure measurement and the heart rate measurements and the ratio which we have seen, the heart rate, increase in heart rate by fall in systolic blood pressure is 0.2 and 0.13 in tilt table test. So this is characteristic feature. You can see the individual supine, head up tilt test, and there's a fall in the blood pressure. The time is about 10 minutes. 10 minutes is the new definition. You have to check for 10 minutes. If you don't have, it's very simple. And in your OPD, you can diagnose autonomic nervous system dysfunction, provided you keep in mind the change in heart rate divided by change in systolic blood pressure less than 0.5 beats per mercury is highly suggestive of neurogenic orthostatic hypotension. So another thing is the anormosmia. Normosmia is again a feature of MSA, and then if with normosmia there is no PD. Polysomnography can confirm their RBD. Then you do an ultrasound bladder and post-void residue should be at least 140. Here in this case 140. It should be more than 100 as we already studied. So the clinical features, subtle motor signs, subtle cellular signs will help us in coming to a conclusion. So, and the possible prodromal MSA in this case is a sporadic progressive adult, more than 50 years. This lady is 58. And there is a polysomnographic evidence, and there is neurogenic orthostatic hypotension, more than 20 by 10 millimeters of mercury, BP drop within 10 minutes of standing or a head up tilt. Urogenital failure, there is erectile dysfunction in males, not in this case, below the age of 60 years, combined with unexplained voiding difficulties with the post-void urinary residual volume more than 100 ml and or unexplained urinary urge incontinence. This lady has 141 ml. And there are subtle Parkinsonian signs and subtle cerebellar signs. So the clinically essential, this is the probable autonomic dysfunction is there, Parkinsonism is there, and there is a Babinski sign, which will make it a probable diagnosis. So you can do a levodopa challenge. You can see some whenever you start an individual on levodopa, so you can see the individual who has a predisposition to MSA diagnosis, they'll have a fall in blood pressure, which may require midodrine at least at sometimes, or you can give some other drug or volume expansion. But you see the response in the form of UPDRS 3, that is a motor scale, is not very mixed. There is no dramatic response. It's only 13 or 14% in this case. And you can see the hot cross bond sign, the cerebellar atrophy, and you see, so then the pitominal sign. These are present. This is a gradient echo imager, SWI image, where you can see the pitominal sign. So this is possibly a, um, a probable diagnosis of MSA. There's a poor levodopa-responsive Parkinsonism, rapidly progressive, discolored feet, Babinski, putamen pons, and MCP. All these features will make you feel that it is. So clinical examination is very important. So I conclude by saying diagnosing MSA requires motor, non-motor symptoms, autonomic features, sleep and olfactory functions, new MDSI criteria for earlier and more reliable diagnosis. The inclusion of possible MSA in the new diagnostic criteria enables an earlier identification of the disease. So I think with this, we can say that we have come to the end of our talk on MSA. And that I think if somebody wants to ask a question, and we can have some discussion on this, but you can unmute yourself. So the important thing what I said was that we have now changed diagnostic criteria. We are able to diagnose bedside. Our autonomic nervous system evaluation has changed. We have to wait for 10 minutes, and the fall, significant fall, is at least 20 in systolic and 10 in diastolic blood pressure. So that will make it probable. We have to do a ultrasound to see what is the post-vital residual volume. It should be more than 100 ml, and that's also diagnostic. So these are the important clinical things that have come up. Then another individual comes with postures, and there's antrocholis and camptocormia, and disfigured hands and feet. Also, cold and erythematous extremities swollen. These are all the physical non-motor signs that can help us in coming to a diagnosis of MSA. So this is in short, and if there are no questions or things like that, then I think I will close here. Oh, thank you, ma'am.